We're just waiting for a few more to connect, but it's absolutely brilliant to see the turnout that we have today. I'm Zaf. I'm one of the pediatrics intensivists at Birmingham Children's Hospital, and the ISC chair for the Cape Town conference that we're really excited to have in July. This is a wonderful experience. Amelia, my colleague from Seattle, and I have thought about doing something mostly for trainees around the world globally, and to match them with trainees from low income, middle income and high income country, where they will present their cases, and then we have expert speakers who will be able to give a chat, follow on by a Q's and A's. The session should really last only about 1.5 hours, and hopefully we'll have some learning and shared experience at the end of it. So that is the goal, really. So be kind to our trainees. They're really sharing their experiences, and we would love for you to share your experiences as well. Today, we're really excited to have trainees from Borneo, from Ghana, as well as from the UK. And together with those trainees, they have their supervisors or colleagues. In addition to that, I have my very good colleague, Hari Krishnan, who has a great interest in neurocritical care. And we have two expert speakers, Michaela from Australia and Shamil from South Africa, some real world leading experts in neurocritical care. In addition to that, I have one of my excellent A&P from Birmingham Children's Hospital, Tracy Robry, who will be assisting with moderating today. And we have one of our ex-trainees, well, two really, Chor and Olive from Malaysia, who will be joining us, as well as Omer, another ex-trainee from Birmingham, who is now a consultant in Bristol. So really, really grateful for you guys to assist us today in this program. Remember, it's an opportunity to share your experience, so please keep all the questions in the chat box. And I will now hand over to our first speaker, Q, but I'll get Chor to introduce his trainee. Thank you all very much, and let's have the session.
Hello, hi, good morning, good afternoon, and good evening. Hi, I'm Chor. I'm a pediatric intensivist from Sarawak General Hospital from Borneo Island. Right, it's quite far away from all of you. Yeah, and it's my privilege to participate in this program, and also thank you, Zaf, and the rest for giving us this opportunity for us to share some of our experience in managing critical care children. And it's my great honor to introduce you Dr. Q Fulang. Dr. Q is actually our first year pediatric intensive care fellow trainee. She's a very brilliant and hardworking gentleman. Yeah, I would like to call him as a gentleman. Yeah, the nurses and our colleagues love him very much because he acted very professionally and very kindly. Yeah, and of note that he's also very good in cooking. He's very master in cook. And without much ado, let me introduce Dr. Q, and Dr. Q, the floor is yours.
Thank you very much to Dr. Chor and Dr. Zaf for a very kind introduction.
Hello everyone, I'm Q, Pediatric Intensive Care Trainee from Sarawak General Hospital, Malaysia. Today I'm going to talk about point-of-care transcranial Doppler in managing neurocritical care patients in PICCS ICU. It is time to move beyond pupils and GCS for the bedside CNS assessment and enter the point-of-care transcranial Doppler, a rapid assessment for intracranial pressure, which is similar to the arterial waveform but going through an ultrasound technique. Point-of-care transcranial Doppler is a non-invasive and portable device which is an ideal tool for the PICCS ICU care. Using a phase array probe 2 to 5 MHz placed over the temporal bones using a color spectral Doppler over the MCA. Looking at the pictures of this transcranial Doppler image, we can see circle of Willis similar to the diagram shown here, and this is the bilateral MCA, and we are interested in this bright orange flow towards the probe. And by putting the pulse wave over the MCA, we can generate the waveform characterized by a sharp upstroke followed by a stepwise deceleration pattern. And the diagram here showing you that the patterns of MCA flow velocity to the relation of cerebral pressure perfusion. For the outline today, I'm going to share an intracranial pressure changes after cerebral resuscitation using ultrasound to assess cerebral blood flow, indirect measurements of intracranial pressure, and to look for intracranial bleeding. Present to you an unfortunate 8-year-old girl with a history of unexplained intracranial bleed after a minor fall 2 months ago. She presented acutely with sudden onset of headache, subsequently found unconscious, and she was then brought to the district hospital, which is situated 75 kilometers from the referring center, and she was intubated there in view of poor GCS. An urgent CT scan was done on admission, showing a massive right temporal lobe intracranial bleeding with poor white and gray matter differentiations in keeping to right cerebral hemisphere edema. The bleeding has intraventricular extension, causing effacements of bilateral ventricle and significant midline shift. Urgent cranectomy was done 16 hours after the incident due to the transport issues that causing delay. Post-cranectomy, CT scan was done showing right temporal intraparenchymal bleeding with right MCA and PCA infarction and post-operative changes. The mass effect is getting lesser, whereas you can see the left EVD is inside too. Post-operative vital sign monitoring showing hemodynamic stable, however, noted the ICP is very high, 36. And this ICP waveform is in keeping to critical ICP pattern. Series of brain ultrasound in monitoring ICP, showing likely the child is having right middle cerebral arteriovenous malformations with acute bleed. The ICP is very high, more than 25, even after cranectomy. The first challenges. The question is how to assure that this high intracranial pressure does not compromise the cerebral circulation. Here are the pulsed color Doppler of MCA when the intracranial pressure reading was more than 25. We put on pulse wave. Noted that the RI is 0.75 and the PI is 1.51. From this T transcranial Doppler, we know that despite of high intracranial pressure, cerebral Doppler blood flow is still adequate. Hence, the management was to accept higher ICP. Here I would like to demonstrate you the pupillary assessment using ultrasound in the eyes that are unable to open. Placing the probe to the lateral angle of the affected eye and shine into the non-affected eye. You can clearly see here, pupil on the right side is fixed and dilated, whereas the pupil on the left side is still reactive to light. This is orbital ultrasound showing swelling of the optic disc, right? And when we measure, there is increased optic nerve shift distance. Both are in keeping to papillar edema, suggestive of high ICP. Progressions of the illness. In day 3 post-operation, EVD was dislodged during manipulations. Subsequently, there is no more invasive ICP monitoring. And we notice the child have both pupil fixed and dilated at day 4 post-operations, and the right cranectomy sites are full and tense. Here come another challenges, and the question is how to estimate targeted MAP to achieve optimal cerebral pressure perfusions in the situations when the invasive intracranial pressure monitoring is not available. What we did is we performed a bedside transcranial Doppler, and you can clearly see here review a reversal blood flow. The RI is 1 and the PI is 3, indicating cerebral blood flow compromise. In view of clinical and ultrasonic evidence of high intracranial pressure, we upgraded to Tier 2 management. Treatment given was burst suppression with thiopenton, hypothermic therapy, 3% hypertonic saline infusion, and inotropes to bring up the MAP. We were trying very hard to fine-tune the optimal blood pressure to maintain good cerebral blood flow. With a MAP less than 80, reversal flow seen in keeping to worse cerebral perfusion. But when we bring up the MAP to 80, we still notice that the cerebral pressure perfusions are compromised. And when the MAP is reaching 95, the cerebral perfusion improves. And finally, with a MAP of 100, cerebral pressure perfusion seems to be even better. Hence, we decided to keep her on a higher MAP to maintain intracranial perfusions. However, 5 weeks after operation, we noticed that the child had vomiting and desaturations, bulging of right cranectomy site with concomitant bradycardia and hypertensions, and true enough, ultrasound cranium shows massive right hemispheric bleed with midline shift. Urgent CT scans performed showing large massive right parenchymal bleed and intraventricular bleeding causing significant mass effect. Cerebral resuscitations restarted and completed in 48 hours. She went through another surgery. Left EVD is inserted and embolizations of right temporal PL AVF done 3 days after EVD insertion. CT scan repeated 1 week after operation and review lesser intracranial bleeding, lesser hydrocephalus, and less cerebral edema. 3 months after a long fighting journey, we finally managed to win her down to BiPAP ventilations and discharge her home. Here present to you our great fighter who is now currently under palliative care team coming for routine review. And finally, neurocritical care is a roller coaster ride. It had a lot of surprises throughout the day and you will never know what is around the corner. It has ups and downs, but it is up to your choice to scream or even enjoy the ride. I hope all of you enjoy the case that I have shared just now. With that, thank you very much. The end of my presentations.
That is quite impressive, but I will take questions at the end, so please put your questions in the chat box, and I'll hand you over to John to introduce Justika. Over to you, John.
Hi, I'm Dr. John Adebiapia. I'm a pediatric intensivist at the Kofuanochi Teaching Hospital. Kumasi is the second largest city in the middle belt of Ghana. I present to you, my background is the pediatric intensive care unit in my hospital. And behind that, we have the other floor. So that is the hospital where we are, and this is where we are from. Justicia is a medical officer. She's actually not a resident yet. She's preparing to write her primaries for pediatric residency, but she has been attached to the pediatric intensive care unit as a medical officer currently. as one of the medical doctors who help us manage cases at the unit. She is presenting and will be highlighting some of the challenges and then the available resources and some of the challenges we have within our unit managing case in low resource limited setting like us in Ghana. So thank you very much. Justice Yap.
Hi, thank you very much for that kind introduction, Dr. Adebiapia. Share my screen and then I'll begin. Good morning, good afternoon, good day, everyone. And thank you so much for the opportunity to present this case. So this is a case of a traumatic brain injury. Okay, so I present a 6-year-old male with an estimated weight of 20 kg. He presented to the ER on the 7th of November, 2021, was admitted same day to the PICU and was discharged on the 23rd of October, 2021. So for the history, it was taken from the patient's father, who is the primary caregiver. This was a previously well child with no known chronic illnesses. He was well until a day prior to admission when the tricycle he was sitting on collided head-on with another tricycle. He was thrown off the tricycle, landing on the ground, and as a result of that, he lost consciousness immediately. He was sent to a peripheral hospital and was subsequently referred to Komfo-Anokye Teaching Hospital Accident and Emergency for further management. On direct questioning, there was no bleeding or loss of fluid from the ear, eye, nose, or throat. There were no seizures, no vomiting, no difficulty breathing, no hemoptysis. On initial assessments at the accident and emergency, his airway was patent but at risk on account of the low GCS that he had. He was breathing spontaneously. He was not in respiratory distress. He had a respiratory rate of 30 cycles per minute. He was saturating at 98% on intranasal oxygen at 2 liters per minute. The air entry was adequate. He had vesicular breath sounds with no added sounds. For circulation, he had warm extremities, capillary refill time less than 3 seconds. He had a pulse rate of 147 beats per minute. It was regular and of good volume. For heart sounds, the first and second heart sounds were present with no added sounds. For disability, he had a GCS of 7/15. For eye, he scored 1, motor 5, verbal 1, with his pupils about 2 millimeters reactive to light, and a normal tone in all limbs, and an RBS of 10 millimole per liter. For exposure, he looked ill. He was not pale. He was febrile with a temperature of 38.0 degrees Celsius. He was anicteric, well hydrated. He had a blood stain in the right ear. He had a right raccoon eye, abrasions on the right temporal region. He also had a soft tissue swelling extending from the right temporal region to the right jaw. And he had a splintered right thigh and skin traction. An initial diagnosis of a severe traumatic brain injury to rule out a base of skull fracture, to rule out an intracranial bleed, and also to query a right femur fracture was made. So the patient was admitted to PICU 3 hours after presenting to the A&E. For this child, he was quite fortunate because of our limited bed space that we have. Usually patients that come are on a waiting list. So he was quite fortunate to be admitted quite early. We did an FBC. The HB came out as 10.6 gram per deciliter. He had a platelet count of 301 times 10 raised to the power 9 per liter and a WBC count of 22.32. A BU creatinine was also done with a urea of 5.99, creatinine of 42. They were all normal. Sodium of 145, potassium 5.1, chloride, which was mildly a little high, 115 millimole per liter. Cultures were taken, urine and blood cultures, samples for urine and blood cultures were taken. The child was nursed in the midline with the head of the bed elevated at 30 degrees. He was started on anti-seizure medications, IV phenobarbital, 50 milligram BD, also started on hyperosmolar therapy, IV 3% hypertonic saline, 60 mils TDS, and the child was intubated for mechanical ventilation. So for day 1 on PICU, the child was being mechanically ventilated with a target PaCO2 of 35 to 40 millimeters of mercury. Unfortunately for us, we do not have the luxury of doing around-the-clock ABGs. First of all, it's expensive. And unfortunately, even at this point, the machine had actually broken down, so we don't even have any ABGs for this child. And we were able to get a head CT done, which showed that the child had a diffuse axonal injury, contusional hemorrhages. He also had a fracture of the left floor and lateral wall of the right orbit, and a fracture of the medial wall of the right maxillary sinus. We did a chest X-ray, which was normal, and an X-ray of the femur, which showed a closed right proximal third fracture of the femur shaft. So this is just a snapshot of the head CT. These are axial head CT images. On the left is showing us the brain window, and on the right is showing us the bone window. Unfortunately, I couldn't get the video to be able to go through so that we'll be able to appreciate the fractures, especially in the right orbit and the maxillary sinus. But I believe you can see the soft tissue swelling and can also see the contusional hemorrhages that the child had. So on the second day of admission, the patient developed SIADH. This was evidenced by the low urine output. The child had 0.4 mils per kg per hour. He had retained almost about a liter of the fluid we had given over the past 24 hours. And despite the fact that the child was on hypertonic saline, he had a serum sodium of 138 millimole per liter. For the third and fourth days, the patient had a low HP of 7.3 gram per deciliter, and the child was hemotransfused. At this point, the GCS had improved marginally from 5T when he was intubated to 6T, and the urine output had also improved to 1.2 mil per kg per hour. On day 5, the child had seizures. They were generalized tonic-clonic seizures, which were controlled with IV phenobarbital, and the ventilatory support was switched to invasive CPAP. So the next significant event was on day 8. At this point, the GCS was 5T on 15. So a request for a repeat head CT scan was made. This was due to the fact that the GCS had not improved, and the child on day 5 had seizures. So we wanted to know is there a new bleed? Is it that he has cerebral edema? Is something worsening in the brain? So we requested for a repeat head CT scan. So by day 9, there was a bit of progress. The bilateral raccoon eyes he had was resolving. The soft tissue swelling that extended from the right temporal region to the right jaw had also improved. The hypertonic saline was weaned down and stopped on day 9. And a tracheostomy was done on day 9 on account of prolonged intubation. Even though the head CT scan was requested on day 8, it was done on day 10 due to financial constraints. So we got the reports back, and it showed that the intracerebral hemorrhage was resolving, and the child still had a grade 2 diffuse axonal injury. And it also showed the old fractures of the right orbital and maxillary sinus, but there were no new intracranial bleeds or cerebral edema seen. And also on the 10th day, an open reduction and internal fixation with flexible titanium nails were done for the closed right femoral, proximal third femoral fracture he had. So the patient was transferred out of the PIC to the main ward 7 days after the tracheostomy. And in total, the child spent 16 days on admission. Also on the ward, he spent another 16 days on admission. So in total, he spent 32 days, and he was discharged. He's been coming for reviews at the physiotherapy unit and also being seen at the ENT unit. So this is the end of my presentation. Thank you very much for your audience.
So our next speaker will be coming from Bristol Children. Thank you very much, Jessica, for sharing your talk. If you can stop sharing your slides, and we'll have Tom. Is Tom is there? Yeah. So I know Omer has dropped off. Tom is one of our UK grit trainee. These are specialists trainees who have an intention of becoming pediatrics intensivists and have gone through the training program. Tom is coming from Bristol Children's Hospital, and he will be sharing with us today his case presentation. Over to you, Tom, and thank you for joining us.
Hi, Zaf, thanks so much. I'm just going to bring my slides up. Great, can I just check, can everybody see the slides there?
Yes, all is good to go.
Wonderful. Okay, hi everyone, my name is Tom. Thanks very much, Zaf, for the introduction. As you said, I'm a trainee in Bristol, which is in the southwest of the UK. It's a real pleasure to be here. And thanks so much to Kin and Justika. I really enjoyed your presentations. It's really fantastic to hear about how people are managing these cases in different countries across the world. So I really enjoyed that. So the case today I'm going to be presenting to everyone is a case of traumatic brain injury. It's a 15-year-old girl who fell from a horse onto concrete, unfortunately, on the 12th of April 21. PCS3 at the scene. She had a brief period of CPR, and when the emergency team came, it was a kind of an advanced emergency team with doctors present who intubated and ventilated the patient on scene. She was then, other clinical findings, she had obviously had a head injury and was bleeding from the left ear with a right pupil dilatation. Other injuries she had were relatively minor. She had some pulmonary contusions which weren't really significant in influencing the ventilation. She also had some minor abrasions of her arms and legs. So just wanted to give a bit of a timeline about what happened in the coming hours. So the incident happened at 5:30, and within an hour she'd been stabilised and helicopter transferred. Hello?
Keep going. That's a.
Oh, sorry.
That's a bit.
The slide's changing. Did the slide change?
You're on your timeline now. Just keep going.
Perfect. Yeah. Sorry, everyone. So within an hour, she'd been transferred by helicopter to Truro Hospital, which is in the far southwest of the UK. As you can see, she had a CT head within 20 minutes of arriving in the hospital. And then by 7:30 p.m, so within an hour of the transfer, she'd been discussed and accepted by Bristol Children's Hospital. She was transferred and arrived about 2.5 later at Bristol Children's Hospital by the same helicopter which had been waiting for decision about her ongoing care. And then by 11 p.m, she was in neurosurgical theatre, which I'll go on to explain. This is just a bit of a geography in the UK and some pictures to help you understand the context, I guess. So this is Truro Hospital, which is in the southwest where she was first brought in. This is a map of the UK. So the red region is the southwest. The cross at the bottom is Truro, and the cross further up near the top of the red section is Bristol, which is a 269-kilometre journey. It takes about 3.5 hours by car, but it's much quicker, obviously, by helicopter. And this is Bristol Children's Hospital. So initial CT head showed a right subdural hematoma with right frontal and bilateral hemorrhagic contusions and midline shift, partial effacement of the right lateral ventricle, and then there was also extensive fractures of the mastoid bone through the occipital bone and into the skull base, which unfortunately you can't see in this CT. She went to neurosurgical theatre. They inserted an intracranial bolt with an opening pressure of 25 to 30 millimeters mercury, which was, she then went for a repeat CT scan, and the pressures were persistently raised. So the neurosurgeons decided to do a large craniectomy. So they did a right-sided frontotemporal parietal decompressive craniectomy. She was then transferred to pediatric intensive care. So I'm going to focus on the first 48 hours really after the neurosurgery. I'll tell you a little bit about how the case developed after that, but we'll focus on that first stabilization period. So this is just a run through of the different kinds of monitoring which we're using for the patients on PICU. So obviously kind of basic things, pulse telemetry and oxygen saturations. We had an end tidal on the ventilator, temperature monitoring and invasive arterial monitoring. Also had the intracranial bolt, which was giving us the intracranial pressure, so we could work out cerebral perfusion pressure. And we also had cerebral function monitoring, CFM, which I'll go through a little bit more in a minute. And serial blood gases, as we're lucky enough to have access to be able to do those relatively easily, and rapid access to CT and MRI. So on day one, she had kind of the full package of neuroprotection. I'm sure everyone's familiar with this, but PCO2 4 to 5, temperature targeted for 35.5, and that was maintained with a cooling matter. She was having some increased temperatures, nursed at 30 degrees, and aiming for sodiums more than 150 millimoles per litre, with boluses of 2.7% hypertonic saline. She was paralysed with deep sedation and prophylaxis for seizures with levetiracetam Keppra. So this is a graph showing the first 48 hours of the blue line is intracranial pressure, and the orange line is kind of calculated cerebral perfusion pressure, which we calculated from the mean arterial pressure, which we're measuring. So as you can see, there's kind of a general increase in the numbers over 48 hours. Obviously, we're hoping to keep the cerebral perfusion pressure below 60, and ideally with ICP below 20, but definitely below 30. So there should be a series of red dots coming up here, which for some reason doesn't appear to be showing. But these red dots were given multiple times throughout the admission. So wherever you see a spike in the ICP, there was one at 6:30, for example, one at 6 o'clock, 6:30, 8:30, and wherever you see these increases, just to demonstrate that the rises in intracranial pressure were promising us to give these boluses of hypertonic saline. Apologies if those red dots haven't come up, so that was quite a nice demonstration. She was requiring a noradrenaline infusion really from the get-go. At first, it was just started at a very low rate of 0.02 miles per kg per minute, but over the course of her stay in the paediatric intensive care unit, she required noradrenaline at relatively high doses of 0.2 miles per kg per minute to maintain her cerebral perfusion pressure at above 60. And you can see there were some periods where we weren't able to achieve that, but largely we were able to. This gap in the readings is when she went for a CT head, and I'll explain and go through the findings of that shortly. And then when she returned from the CT head, we started a thiopentane infusion to induce burst suppression and a barbiturate coma. And finally, this gap here is when she went for an MRI head for kind of neuroprognostic purposes, which I'll explain shortly as well. And finally, she had an external ventricular drain inserted at this point because we were having kind of had made the decision to continue treatment, and she was having these persistently raised pressures. So that was with the hope of controlling that. This is an image from the cerebral function monitoring. So what you can see here, this line kind of gives you an indication of the level of brain activity. This is kind of usually three probes placed into the scalp, just to give kind of a rudimentary measure of cerebral function. But it's very useful, particularly for detecting seizures, which may not be apparent when you've got a patient who's paralysed and sedated, but also to guide treatment, and particularly induction of burst suppression. So this was very useful when we started the thiopental to give us an idea that we had achieved burst suppression. So you can see the change in the pattern here is an indication that burst suppression was achieved. So this is really just of interest. I mean, you can see that the craniectomy with the skull missing there. And this is this image from the CT taken just prior to insertion of the external ventricular drain. At 48 hours, we did an MRI head. This was primarily to get a sense of whether there was any evidence of hypoxic ischemic injury, either from the period when she had CPR at the time of the incident or due to any issues with not achieving cerebral perfusion throughout. As you can see, the findings are really consistent with previous scans, but there was no evidence of global hypoxic ischemic injury. And so at this point, after extensive discussions with the family, we decided to continue with treatment. And so that was very useful in guiding that. I'm going to move on to just kind of talking a little bit more about what happened with the case over the next kind of days and weeks now. These are just a series of CT heads taken throughout the following 2 months. And you can just kind of see the way the hemorrhages are organizing and the cerebral tissue is kind of changing there, just out of interest really. So significant events in PICU. She was on noradrenaline for 28 days, midazolam infusion for 23 days. At one point, she developed a really nasty bacterial sepsis, requiring escalation in antibiotics multiple times due to an arm abscess, which required evacuation and drainage. And I think that was secondary to a cannula at the time. She had a tracheostomy on day 18 of admission, and she developed diabetes insipidus and a hypothyroidism secondary to the brain injury, and so was managed with vasopressin infusion and started on levothyroxine. So she had a very, very complicated stay. She was admitted in PICU for 76 days in total, and she'd been entered into neurorehabilitation program at Bristol Children's Hospital, which includes speech and language therapy, physiotherapy, occupational therapy, and other services to kind of support patients over the following months to regain function as much as possible. So she's actually still in Bristol Children's Hospital undergoing neurorehabilitation, and it's likely to be there probably for a further 6 months at least. She is fully dependent. She's wheelchair bound, but has made progress. She's making slow, consistent progress with her intentional and voluntary movements, and she's following commands. And she's starting to develop functional use of a pen, so there has been some progress over the period of admission. So I think the main learning points we wanted to focus on was the use of ICP trends to guide medical therapies and surgical intervention, and the use of cerebral function monitoring as a marker of treatment efficacy. And as I mentioned also, although it wasn't a factor of this case, kind of managing seizures. And finally, just this kind of, I guess, privileged access to all the equipment and investigations that we do have in Bristol, but particularly with the comprehensive neurorehabilitation service, which provides patients with really kind of fantastic care from the various allied specialties in making their recovery after their stay in PICU. Thank you very much for listening, everyone, and that's the end of my presentation.
Thank you, Tom. Wonderful presentation, and it's great to see the series of cases that is coming from the Global Committee. I'll pass over to Harry to introduce Michaela.
Hi, everyone. Thank you for joining, everybody, and thank you in particular for the trainees who did a really good job. It's my pleasure to welcome Michaela Wack, who is an academic pediatric intensivist and a neurologist. She has expertise in long-term neurological outcomes, EEG monitoring, is a part of Piccolo, and she's from Brisbane. Without much further ado, I think Michaela's now ready, so I'll hand over.
Hey guys, can you hear me?
Loud and clear, thank you.
Wonderful. Thanks for this opportunity. It's really exciting to see so many trainees present from different parts of the world. I've worked in different settings, both in Europe as well as South Africa, and now I'm in Brisbane in Australia, down under. And I've been asked to summarize a little bit some of the challenges of the cases we've seen today. So what why can't we recognize neurological and neurosurgical emergencies well? If patients present to ED or even ICU, our nurses and ourselves, like really every clinician, knows how to monitor the heart with heart rate and blood pressure, or respiratory systems with respiratory rate and saturations. But neuromonitoring is really challenging because the tests we do have that give us real-time information might not be accessible. And even if we do have them, they don't really give us all the informations. So what we need is clinicians to examine the patients, unless they're paralyzed, of course. And the systems that have been designed to recognize deteriorating patients are not designed to pick up neurological or neurosurgical signs or symptoms. Once we know this patient is deteriorating, relevant imaging might be difficult to access or organize, and it really depends on good collaboration between ICU, radiology, neurosurgeons, neurology. So it's tricky in complex teams. So what I'll briefly talk about is what are causes of raised ICP in children? What are the signs and symptoms we're worried about? How do we try and rapidly work out that something's wrong? What imaging modalities do we have available? What are our invasive and non-invasive monitoring options? And I'll talk a bit more about non-invasive, but the follow-up speaker, I'm sure, will have lots of insight into that. And what treatment modalities do we have available? And why do we care? Starting with definitions, if the intracerebral pressure is up, it's either because the brain tissue has increased because of edema, or blood or the CSF are expanding. And the typically accepted treatment thresholds that we'll talk about in more detail later are 20 millimeters Hg or 27 centimeters of water. What are the high-risk groups of patients? It's the moderate to severe TBIs, especially the non-accidental injuries. It's patients with infection like meningitis or encephalitis. It's metabolic patients, for example, hepatic encephalopathy. We see patients with vascular abnormalities. And a typical example where we can get really good long-term results if we recognize it early is patients with malignant MCA stroke. We also see patients with brain tumors or other causes of hydrocephalus. But really for all those patients, unless there's a clear cause and we can manage them in a time-critical fashion, the time they spend with raised ICP can potentially lead to global brain injury and increase their mortality, but also their morbidity. And we've seen examples of that, that the trainees have presented what this might mean for the child and family for the future. So in pediatrics specifically, traumatic brain injury and intracranial infections are the most common reasons why we might see patients with raised ICP and PICU. And we really need to coordinate this well. We don't necessarily have the patient numbers to generate the high-grade evidence for therapies that we see in the adult trials. But we do know that if we collaborate and have pathways in place, we can improve the outcomes. And that's not just in stroke, but that's also true for raised ICP. So I've briefly summarized the symptoms we're very familiar with, but that sometimes can trick us. Headaches can be tricky, especially in the smaller children. Nausea and vomiting have multiple causes. Certainly acute NSAID, altered mental state, is always an absolute warning sign, and we need to work out the cause of the encephalopathy. Hypertension, bradycardia, Cushing's triad, that's kind of further down the track. So that's really, we need to get some action going. Same for flexor, extensor posturing, and pupillary changes. But quite a number of those are really dependent on how familiar we are with examining patients in different settings. How much history you get, and if they're small children or once they're sedated and paralyzed or critically unwell for other reasons, it's really difficult. Papilledema doesn't always show up, and some of the patients that with chronic signs of raised ICP can present when they're decompensating. And once we have identified there's a neurosurgical emergency, we really want to get our ABCs or brain-directed therapies right. And the question is, how do we work out whether there is raised ICP and what the etiology might be, which imaging modalities might help us in what settings, and do we have access to them? And especially in Australia, where we're quite regionally challenged, it really depends on where this child presents when I'm on retrieval call, what imaging modalities, if at all, I might have available. So neuroimaging is the most commonly utilized non-invasive modality to work out whether there is raised ICP, but they don't always show up straight away. So an initial negative CT can potentially trick us. And really a non-con CT will give us the answer to absolute neurosurgical emergency. So the way I explain it is that if you really think this patient's very acutely deteriorating and they'll have either an expanding hematoma or a hydrocephalus where the neurosurgeon's basically got his theatre ready to go, then you want a non-con CT because that's really your most, your quickest way into theatre. And findings that you might say is midline shift effacement of the CSF spaces. And I'll talk a little bit more about the optic nerve sheath diameter, which is a newer marker that's not been as well described in children. But as I've said before, an early non-con CT does not mean that we can be reassured if there's signs and symptoms. It just means that there's nothing for the neurosurgeon to do at that point in time. MR is a little bit harder to facilitate and to access in certain centers. Certainly in our center, we've got excellent access to MR, and our anesthetists and ED, like we've got good systems in place, but it still means that you might need an anesthetic, which can cause delays, and that you need imaging protocols where they don't take an hour to scan the child, but that might only take 5 to 8 minutes. Again, findings that indicate raised ICP are midline shift or effacement of your CSF spaces, and other more interesting emerging adult measures like the elastins in the index, where you measure your ICP volume change through the cardiac cycle, or cerebral blood flow, which is usually in a non-con MRA, CSF flow velocities through the cerebral aqueduct, which is again a more dynamic measure, and optic nerve sheath diameters can be useful, but it is difficult as they've really only been developed for adults so far in terms of reference ranges. But the additional information you might get is why they've got raised ICP. And that means that you might be able to instigate targeted management on top of your neuroprotection and a more general management of raised ICP. And you also get some prognostic information. Ocular ultrasound is a point of care test that centers that are familiar with point of care ultrasound are using more and more, and we've certainly started using this. It's not really giving you a trend, so it's a kind of yes/no whether there is raised ICP or not. There's really not a lot of pediatric data, but it's an evolving modality that in the right hand, in the right center, with experience and more international multi-center data might actually become more and more useful. And can't really talk about transcranial Doppler without mentioning Nikki, who I believe many of you would know, especially in the US as well as sub-Saharan Africa. And I've grown up in Europe, where we have used a lot of ultrasound, and certainly transcranial Doppler is something we have used for a long time. And it's in Australia, the systems are a little bit different, and it's more kind of a radiology test. It's well established in sickle cell children with stroke and adults for teenagers for vasospasm detection, but it's also more and more used for detection of raised ICP. And we've had a wonderful presentation at the very start explaining the basic principles and how it might be used. And really what you see is a dynamic test that can tell you over time where this patient might be heading. So not just at one point in time whether the pressure is up or not, but you can follow your flow velocities and PIs. It's been associated with neuroprognostication, but more importantly, it might actually give you some treatment targets that you can follow. And interestingly, we're looking at using it in assessment of autoregulation. But really, the gold standard is invasive ICP monitoring, and you can either use a microsensor or you use an EVD, which allows you to actually drain CSF, and it can be part of your management strategy. It does mean, though, that you require access to theatre neurosurgeons in an ICU, art lines, central lines, and the risks in terms of infection, hemorrhage, malfunction, malposition might prevent you from using it in some patients with severe coagulopathy, say with hepatic encephalopathy. So why do we want to know about raised ICP, and why do we want to follow ICP trends, and why do we need dynamic assessments of whether autoregulation is intact and what your cerebral perfusion pressure might be? We're all very familiar with the Brain Trauma Foundation guidelines, and all our centers will have their own pathways of how to assess either ICP, but better CPP, which is your ICP in relation to your mean arterial pressure. And the targets and the evidence base for the Brain Trauma Foundation, unfortunately, when you actually look at the fine print, it's less robust than in adults, but we certainly do have some studies and more data from both retrospective as well as prospective cohort studies that having a neuroprotection pathway and having clear CPP targets can impact outcome if the patients have a underlying etiology that is amenable to treatment. And the question is, which are the right CPP cutoffs? And they might be a little bit lower than suggested by the Brain Trauma Foundation. But interestingly, the ICP threshold might actually be lower than the accepted 20 millimeter Hg in some patients. So that's really a watch the space article. And really, when it comes to neuroprognostication, it is very much dependent on your etiology. Without a known etiology, it's now impossible to neuroprognosticate. But for certain conditions like severe TBI, we do have good multimodal systems of prognostication, and some of them are built on adult data, but we're certainly currently involved in a multicenter trial that predict TBI that looks at pediatric multimodal monitoring information to create more robust systems of neuroprognostication. In infection, we also know that targeting CPPs can improve outcomes. Again, it very much depends on the severity of the infection. We've all encountered patients with significant strep meningitis that despite what you do, they will deteriorate and cone, but most infective meningitis or encephalitis, we can intervene on time to antibiotics, but also targeting our cerebral perfusion pressure and having good neuroprotection measures can impact our outcome. This is a table that looks at other multimodal monitoring of not just ICP and CPP, transcranial Doppler, but also other measures like cerebral oxygenation and cerebral metabolism that the next speaker will speak to a little bit further as well. But this is again an evolving field, and we have some data from adult studies that guide interventions that are applicable to teenagers, but there's very limited data in pediatric patients. There's really usually single center treatment pathways as part of a trial that we would use those to target treatment. And these are the two bigger trials we're familiar with that have shown some impact on outcome. I'm nearly at the end of my talk, but what I did want to draw your attention to, and certainly there's been a huge practice shift in our organization, that we do use hypertonic saline over 20% mannitol for the obvious reason that with mannitol you get your osmotic diuresis and you actually sacrifice some of your volume, whereas with hypertonic saline you increase your circulating volume while you're still controlling your ICP. And I want to thank my team, and really why we care about ICP monitoring, but also intervention, is so we can follow those patients up and hopefully make a difference to them and their families.
Thank you, Michaela. Fantastic talk. Harry is still there. I'll pass over to Harry again to introduce our next speaker, and then we'll go to the bottom with the Q's and A's. Really, really exciting morning. Over to you, Harry.
Thank you very much, Michaela. It is my pleasure to introduce Dr. Shami Al-Sali, who is the head of pediatric care and medical director in Red Cross Children's Hospital in Cape Town. I believe that that is one of the largest hospitals in the world, and if not the largest hospital in sub-Saharan Africa for sure. And he's part of Professor Andrew Argent's research group, who have been prolific in providing us with the knowledge and the evidence that is required worldwide. So thank you very much, Dr. Sali.
Hi there, everybody. Thanks for the kind words, Harry. We've got a very active neurocritical care research group headed by Professor Tony Figaji. Unfortunately, Tony's traveling the world. He's a very popular speaker. Professor Anjit has retired. I'm not sure if he's in the audience. Maybe he's in the audience. But that's the view of Cape Town that I think is anonymous with football, with tourism. And I'm sad to say that the WFPICCS meeting is going to go virtual this year, and you guys aren't going to get to come to Cape Town, but maybe you are, or it'll be an excuse to come and visit. You know, I've really enjoyed the cases from the trainees, Michaela's talk as well, and I'm just struck by the differences in resources in various places around the world. And I think Michaela said it, you know, I think when we're dealing with children that have injured brains, time is critical. And often in resource in low middle income countries, time passes so quickly. And we'll talk a little bit about why time is important as we go through this. Let's move my slides. Just looking at this was published late last year, and it's a systematic review looking at the outcomes of children in low middle income countries, so perfect for the setting, over 20-year period, really, looking at observational data. They looked at 136 studies, included a massive 170,000 children from 32 low middle income countries. I mean, the nature of illness, the nature of the injury to children is often road traffic accidents. But there's falls, there's many accidents where children have injured brains. Mortality is quite significant from the study, sort of was 7 children per 100. But worryingly for me is that 25% of these children in low middle income countries left hospital with some mental, physical, functional deficits, which in poorly resourced countries means that these children have limited access to rehab facilities, and their long-term prognosis isn't as good as it could have been if they have the appropriate interventions. This is a typical street in South Africa, and I'm sure in many low-income countries, children playing in the streets, playing soccer, that's their playground. We've got drivers that are intoxicated, who don't obey rules, and often our kids are then involved as pedestrians in motor vehicle accidents. We have gang-related shooting. There are war zones, not in the Ukraine, but in neighborhoods and children. We've got one in the ICU at the moment, a child with a gunshot wound to his head. So the trauma, the pathology does differ. We can't do anything about the primary injury. We're physicians, we can advocate for rules, for government policies, for driving regulations, but we often can't intervene in that primary injury. What we can manage though, and this is where time is the essence, we can impact on the secondary brain injuries. This is where children, when they present to medical care, that there isn't a delay in intervening. And part of the resuscitation is vital. Part of that initial resuscitation where you make sure that they aren't desaturated, that you make sure that they have a perfusing rhythm, perfusing blood pressure, that they're not going hypoglycemic is vital, because you can potentially save injured brain. Vital to know levels of consciousness. Are they deteriorating? There's no substitute for good clinical examination to pick up abnormal neurology and to guide your treatments. I think I must have missed a few slides further back. I'm not sure. I spoke a little bit about resuscitation. I missed that slide earlier. But fortunately, very few children have cervical spine injuries, but you've always got to keep it at the back of your mind. About less than 3% of children with severe traumatic brain injuries have C-spine injuries. You have to protect that C-spine. Intubation and ventilation can be tricky when you don't have trained personnel, when you have paramedics on the road, or you have very, very basic resuscitation teams. So often when children have a decreased level of consciousness, their airways aren't particularly well maintained, and they often have desaturating episodes. There's a delay in resuscitation, so blood pressure isn't necessarily maintained. For that. Probably, I think Michaela mentioned about the probably what most units are using, the guidelines that were published. I think it's the third iteration of the Brain Trauma Foundation guidelines. It came out in 2019. Maybe just to note that these guidelines were really, a lot of the data is extrapolated from adults, really few good pediatric studies, and a lot of expert opinions. So how relatable the guidelines are or applicable these, or how can you roll them out it's very difficult to roll them out in low middle income countries. I mean, this is a really busy slide where and I'll break it up to sort of talk you through some of it, is where children with traumatic brain injuries with a GCS less than 8 have an urgent CT brain to try and determine the pathology. Without a scan, it's very difficult to know what you're dealing with. We'll break it up. We'll talk a little bit about managing ICPs, about why it's difficult to aim blindly at CPPs, cerebral perfusion pressures. We'll talk a little bit about brain oxygenation. So no matter how good I am, I'm a pediatric intensivist, I can't do anything about this brain. So we need good imaging. We need a surgeon with the ability to actually drain any intracranial lesions. Baseline care, you know, there's nothing fancy, but good opiates, benzodiazepines, should be sufficient to just keep children sedated. And it's the simple things, keeping the head in the neutral, head in the midline, head ups, and making sure that they're well oxygenated, that you're keeping CO2s within normal limits, they're not becoming pyrexial, giving them a reasonable hemoglobin, keeping it above 7. I think seizures is probably the most difficult thing. There's I think the incidence of non-convulsive status is high. And unless you've got access to EEG or amplified AEG monitoring, it's very difficult to pick up a child who's fitting, making sure they don't become hypoglycemic as well. In terms of ICP, there are many mechanisms for raised intracranial pressure. And unless you get it right, you're going to struggle. Is the ICP high because of a swollen brain, or a child is having seizures, or impaired autoregulation? So if you're looking at maintaining ICPs, you need to be considering intracranial pressures and cerebral perfusion pressures, brain oxygenation as together rather than targeting them individually. I think putting in an EVD and draining CSF is great, but often the brain is swollen. And it's difficult in a swollen brain with compressed ventricles to get an EVD in. But that's an easy way to, if you have it in place, to drop intracranial pressures. Targeting ICPs, difficult. Where does the magic number of 20 come from? And there's some debate as to what numbers we should be targeting for. There's a discussion about, I think most units, neurocritical care units, are using hypertonic saline, but it might not be available, and mannitol is definitely an option for treating raised intracranial pressure. And the children, I think there was a question about thiopentin earlier in the unit, but if children aren't responding as a second tier therapy, that's probably where one would be adding it. But regular paralysis, optimizing serum sodiums, optimizing CO2s while monitoring the brain carefully is vital to monitor or to control intracranial pressure. I'm going to skip that. I'm going to talk a little bit about brain oxygenation, and we routinely, and our team routinely puts in brain tissue monitors. And it's useful when you're manipulating ICPs, and I'll show you some graphs later, some real-time data from patients where what changes one gets in brain tissue oxygenation and ICPs and mean airway pressures, arterial pressures. But ideally, we try and keep it more than 10 millimeters of mercury. And hyperventilation for short term is great, but if you're not monitoring brain oxygenation, you could potentially be making your brain more ischemic. I'm going to skip that one. These are some graphs, some real-time data from our unit, from Prof. Gadri's. And I'm going to maybe just talk you through this. And I think autoregulation is something that really, I think, catches us out regularly. And if I can maybe just take you through the bottom, the green graph, which shows the brain tissue oxygenation sort of roughly 12. You've got an intracranial pressure which is sitting at 18, 19, and you've got a mean arterial pressure which is 70. And as the mean arterial pressure starts increasing, can't remember whether it was fluids or a bit of noradrenaline to increase systemic vascular resistance, but you can see the intracranial pressure coming down and a lovely increase in brain tissue oxygenation. This is a child who had lost cerebral autoregulation. And you can see once again, you've got a low mean arterial pressure, sitting roughly 75. You're starting out with a low brain tissue oxygenation. You've got an intracranial pressure, which is sitting roughly at sort of 18 to 20. And as the mean arterial pressure is increased, you can see there's an increase in brain tissue oxygenation. But unfortunately, you get to a point where your intracranial pressure starts going up again. So this is where I think it's difficult to target a specific cerebral perfusion pressure. And when you're chasing a blood pressure, when you're using inotropes of fluid to increase the cerebral perfusion pressure, you have to look at your intracranial pressure. If you don't have an intracranial pressure monitor in place, the recommendation is that you aim for sort of a high normal arterial pressure if you don't have an intracranial pressure monitor, because you can be causing harm by chasing a cerebral perfusion pressure target. This is a lovely graph again, looking just at the child with raised intracranial pressure. This is what happens when the ICP shoots to 30. This happens to your brain tissue oxygenation. That's what happens to your cerebral blood flow. So the brain tissue monitors really gives you an idea of the local oxygenation. They try and place it in an area of salvageable tissue, which is hopefully gives you an idea of what's happening at that one point in the brain. What happens when you hyperventilate somebody? When you hyperventilate, you can see there's a very satisfying drop in intracranial pressure and a nice increase in brain oxygenation. Let's skip that one. So there are many tools out there, and I think different units use different tools to monitor an injured brain, gain expertise in it. We moved, initially we used transcranial Dopplers, but we mainly place brain tissue oxygenation or Lycox monitors, intracranial pressure monitors, and we're moving on towards microdialysis, but these are high-tech interventions which isn't available in many countries. So I'm going to leave it at that and leave you with some parting words with that traumatic brain injuries are common in children. Early recognition, important resuscitation to prevent secondary injuries is vital. You might not have all the fancy toys and all the fancy tools, but you can do basic management and potentially get good outcomes. It's important to monitor what you're doing and understand the pathology that's going on. And there isn't a recipe that's going to fit every child, and you have to individualize the care for the child and the physiology that you have in front of you. And that's it. Thank you very much.
Thank you, Shami, and thank you to all the speakers and the trainee. And I think now we'll open for our Q's and A's, and I'll hand over to Tracy and Olive to field the Q's and A's, and Harry is also there in the background. So Tracy, anything coming through?
Brilliant. Yeah, firstly, thanks to everyone. It's been really interesting to hear presentations from lots of different healthcare systems, different to my own. So that's been great. Thank you. So we've got quite a few questions. I don't know whether Shamil, you want to pick this one up. So there's a question about 3% saline, whether there's any evidence that a bolus versus an infusion is any better.
We actually only have access to 5% saline, but I guess it would probably, so I think if you're in a situation where we have raised intracranial pressure, we tend to give a 3 mils per kg bolus of our 5% saline over an hour, which is fairly effective. I think if you're giving an infusion, we sometimes go onto infusions when we're struggling to maintain serum sodiums when children have cerebral salt wasting. But I think the situation is probably the determinant. If you have raised intracranial pressure, which is critical, I'd probably go for a bolus rather than for a continuous infusion. But if you don't have, we probably use mannitol in that situation as well.
Yeah, I completely agree with Shamil. Hey, Michaela here. But I think there was recently an adult trial, I'm just trying to find it, which actually compared a target sodium versus intermittent boluses of 3% to manage episodes of raised ICP. And they found that if you don't target a certain sodium, but you actually use your hypertonic saline intermittently, like Shamil is saying, in response to what's going on with the patient, they had better outcomes, which makes sense, because what you want to do is you want to increase the sodium content in your blood compared to your brain acutely, to try and get a bit of water out of your brain and decrease your the content in your the bony compartment. So that's how we've kind of written it in our guideline currently.
And do you have a specific sodium level that you target there?
So Tracy, we keep it normal, but we've actually stepped away from saying we want to target, say, supra, higher than normal, say 150 or 160, but we use it intermittently as required. If the level's up to 160 at some stage, so be it.
Yeah.
If the patient's kind of more severely affected, but we certainly wouldn't try and achieve that if the patient doesn't need it.
Yeah, brilliant, thank you.
We would tend to target 145, 150. That's our personal practice at the moment.
Olive?
Hi, Michaela and Shamil. Thank you so much for your sharing. I identify a lot with those who are coming from the low middle income countries. There's always problems with obtaining resources. So I can see a few questions there by Justica and a few more saying that what happens if we do not have the resources for doing transcranial Doppler, or some places just can't offer even blood gases or even imaging. So what do you suggest to me, maybe if we can choose one monitoring, what would be the one monitoring that you would suggest for these hospitals who do not have enough resources to have all the luxury of having all the monitorings that we can have?
Yeah, sure, on a difficult question. But I think one's got to aim for normal first, normal saturations. Most places should have a SAT monitor. I think we also use end-tidal CO2s quite a lot. So if you don't have a blood gas machine, I guess one could also track end-tidal CO2s as a marker as to ventilation. And I guess normal blood pressures. I think if you aim for normal blood pressures, normal SATs, maybe slightly, I work in kilopascals, maybe 4.5 kPAs, low normal CO2s, normal glucose, normal temperatures, you'd be not causing harm that way. Michaela?
Yeah, I completely agree, Shamil. And, I think there is now age-appropriate blood pressure targets and, absolutely, if you can do a non-invasive blood pressure, try and keep it high normal. We would say 95th centile for age and length. And, absolutely, keep everything else normal as you can with what you've got available, and try and work out the etiology as much as you can, because, as Shamil was saying, it really depends what the etiology is, right? Because you want, if it's infection, then it's time to antibiotics. Is there something to drain for the surgeon, source control? And while you do that, you also neuroprotect. Yeah.
I think that's great. There's another question that's just popped in the chat about how could we hyperventilate a patient when we don't have access to blood gases? And I think the use of end-tidal CO2 that you've talked about as a simple monitoring tool would also be really effective in that situation if you were down your pathway looking to hyperventilate your patient and be guided by your end-tidal CO2.
I do know that even end-tidal CO2 technology is expensive and not widely available. So it becomes really, really difficult.
Okay, next one. So we have a question about seizures, whether or not there is any strong evidence that children that have traumatic brain injuries will have long-term seizures or epilepsy developing.
Michaela?
I might take that, being a pediatric neurologist as well. Look, it really depends on the severity of the brain injury and how much parenchymal damage you have. But certainly in the severe traumatic brain injuries, especially if you've got early acute seizures, acute symptomatic seizures, your chances of having epilepsy is definitely more than in the normal population. And, you know, some studies cite up to 10 to 15%, but it's certainly not all of them.
Thank you.
Can I ask what do
There's
you use to manage
sorry.
seizures?
Sorry, Chandra.
Olive, could we ask maybe what do people use to treat seizures? You know, we've shifted. We used to use IV phenobarbital previously, and we're depending on supply, we're probably moving to IV Keppra in Cape Town. What are people doing in other parts of the country for children with acute seizures?
And Shamil, is that a prophylaxis that you would use at the start, or would you just manage clinically seizures and treat them acutely?
You know, I think there's been a change over time. Initially, we didn't use prophylactic anticonvulsants, but more and more we're shifting to using prophylactic IV Keppra from early on in kids with severe traumatic brain injuries. We've just seen so many kids, and it sets you back. So rather get ahead. If you're ventilated and fully monitored in the ICU, we would tend to prophylactically use Keppra.
Perfect, thank you. Harry, did you want to come in there?
Yeah, I mean, I think there are lots of heads nodded when you said levetiracetam or Keppra, but still awaiting evidence. I just wanted to add to what Michaela said. So I absolutely agree. I think the evidence for using prophylactic anti-epileptics essentially has been shown to be effective in reducing early post-traumatic seizure, but somewhat disappointing for prevention of late traumatic seizures. And therefore, our practice certainly has been to give a short course for a few days to weeks and stop, and then only resume therapy if somebody does develop a late epilepsy, for instance, as a therapy rather than as a prophylaxis, if that clarifies. That's one. And then about the hypertonic saline, I think people underestimate the power of the kidneys in maintaining homeostasis, I believe, and that may be contributory to one of the reasons why hypertonic saline infusions or infusions of osmotic dose increasing agents has not been as successful as people imagined it to be, because the kidney essentially counters it.
And I think there's another question here, Harry, about what would you do if you're trying to increment up the sodium level using hypertonic saline and you're infusing it and it's losing through the kidneys and you can't get your sodium above 140, 145. What would you do? Where would we go next? Harry?
Of course, I have some views, but I was wondering whether Michaela or Shamil wanted to pick it up. But my view is that sodium is not the main target. Your main target is ICP and CPP, and therefore you only
completely
need to worry
agree,
about
Harry.
sodium.
Yeah.
Keeping a sodium at a certain number does not necessarily equate to achieving good neuroprognosis. Of course, none of us like low sodiums because we find that occurs in patients who have a lot of cerebral edema. But Chin,
but in all honesty, you know, the more severely affected patients often have AKI, which means their kidneys are actually not working that well. And, you know, personally, I've not seen many where it's hard to maintain the sodium. In fact, you'll see that, you know, in the more severe ones, you'll end up with levels at around 160, and then your chloride's up, and then you've got a metabolic acidosis, and, you know, it takes quite a while for that to resolve. So, yeah. But as Harry says, you really want to treat the patient in front of you and not necessarily achieve high normal numbers if you don't need them.
Thanks, Michaela. Olive?
What's your opinion on craniectomy? I know there is the DECRA trial that shows that it did not offer any benefits in terms of the long-term outcome. But what's your take on early or late craniectomy in those patients with refractory raised ICP?
It's an excellent question, Olive. Sorry, I might just jump in there because, you know, I think the question is not yet. So the question is, if you want to do it, you really want to do it early. But more importantly, which patients might actually benefit. And the way I try and like to conceptualize it is it's the patients with some focal pathology. So say if you've got malignant MCA stroke with evolving malignant edema, and you are at risk for secondary brain injury of normal brain tissue, then it makes perfect sense to decompress because you actually protect healthy brain. And the same is true if you have, for some reason, a TBI that is more focal and you've got maybe some subdural blood that you need to evacuate, and you see a large frontal contusion and not so large counter-accrue, but it's not really this nasty diffuse axonal injury with severe global brain injury. Because I think what the DECRA trial demonstrated very well is that if you've got severe diffuse axonal injury, then taking the lid off does not really improve your functional outcome. Whereas if you've got a more focal brain injury, and that's unfortunately because we don't have high-grade evidence for this, where you need your multidisciplinary team, you need your neuroimaging, you need a good neurosurgeon, and you really need to have that discussion very early. And we certainly are very select about decompressive cranies.
Thanks, Michaela.
I think we probably want to acknowledge rescue ICP as well. So rescue ICP, although was an adult study primarily, it did include children over, I could be wrong, 13 or 10, one of the two years of age, and therefore did have some pediatric, certainly some teenage representation. Essentially, rescue ICP is a randomized controlled trial between patients who had refractory medical ICP, so not needing surgical craniectomy, but for medical ICP, patients that needed thiopentone infusion versus decompressive craniectomy. And it's been interpreted variably depending on which angle or which lens you're wearing or which glasses you're wearing. But one interpretation of that would be, and the numbers could be slightly wrong in terms of what I'm saying, but for every 100 patients that have decompressive craniectomy, you produce 22 additional survivors, but 14 of them are likely to be in permanent vegetative state. And you only improve patients who are alive and not having permanent vegetative state would be maybe about 4 to 6 patients, and and maybe 2 or 3 of those would be with severe disability and needing lifelong care. So it's a very individualized decision making there if you are doing decompressive craniectomy for a medically uncontrolled raised ICP. But I agree. I mean, you don't want to do it once a patient has had this refractory ICP and low CPP for hours and hours, because you can't salvage them. So in that sense, you would need it early. But equally, that's not necessarily an effective therapy to improve outcomes, although it's absolutely effective in reducing ICP. Anybody that has decompressive craniectomy, pretty much if they have wide with dural opening, will have reduction in ICP. But that does not equate to improved outcomes, which is the issue.
Thanks, Harry. Zaf, did you want to come in?
Yeah, I want to bring it back probably to the trainees that presented those wonderful cases. And thank you both, Michaela and Shamil. I know we'll need to tie up in a bit, so probably we'll give another 10, 15 minutes for Q&As, because it's really exciting and it's buzzing in the box. But for the trainees, my question to you, and what are you going to share with your colleagues who are in both high income and low income countries when you're on your intensive care and then you're being told that you're trying to target blood pressure, but you see your ICP is going up? Looking at the graph that Shamil has shown, what are your thoughts on how you're going to manage those blood pressures? What choice of drugs are you going to use in terms of sharing that with colleagues from your other countries? So I'll start off with Justika, then Q, then Tom. I don't know if Justika has fallen off. Let's go to Q and then Tom.
Thank you, Dr. Zaf. So basically in Malaysia, we have the privilege of using ultrasound as a bedside point of care instrument to monitor, as an extra adjunct tool to monitor the cerebral fusion pressure. So again, the difficulties of managing pediatrics neurocritical care is different ages come with different numbers. So here we are looking at more at the trending rather than the fixed number. To answer your questions, how to monitor and how to target is case-to-case basis, right? And we use this bedside point of care transcranial Doppler to look at the waveform, the flow velocity, just like what I've shown you, just shown everyone just now, targeting from a lower MAP, slightly higher than the 50th, 90th centile, then slowly increase until we fine-tune so-called optimal cerebral blood flow. So basically there is no fixed number, but we are looking at the trending and the flow wave. That is what we do in our PQ.
Tom?
Hi, Zaf. I think I've understood the question, but you have to explain it. Tell me if I haven't. But so raised ICP, what are we going to do about the blood pressure targets? I mean, I think the first thing is to try all the medical and surgical things we can do to keep the ICP under control. But I think in tandem with that is to maintain the CCP by kind of keeping an adequate blood pressure. Ideally, I think you would go for a normal blood pressure for that age, but my concern would be if you're kind of getting decreased CCP with a normal blood pressure, that you should think about going to kind of above normal blood pressure to maintain the CCP. Otherwise, you'd be concerned about, hypoxic injury and losing brain tissue. And probably, I mean, my experience has been using noradrenaline to do that. I suppose you could also think about vasopressin and adrenaline as well as kind of adjuncts. But yeah, my experience of that is relatively limited. Yeah.
Justica, are you there?
Yes. Whilst unfortunately we don't have the luxury of ICP monitoring and CPP monitoring, so all we have is the BP monitoring. So we usually just aim for normal to high normal BP values. Yes, that's what I would say. So unfortunately, we can't do that.
Thank you. And I think this is why it's so important for us to, as get our junior doctors from the global community to share their experiences so they can learn from each other. And then we get the expert speakers. So Michaela, Harry, Shamil, looking at your graph, if the trainees, like Justica say, there is nothing in her country, well, in her unit at this moment in time, that is going to give her the luxury, such as Q has. He can monitor his, Doppler and change his blood pressure level to prevent that secondary injury. What advice would you give to the colleagues in those extreme low-income countries to help to prevent, other than you have said today, to prevent those secondary injuries and improve outcome?
From my point of view, it's a tough one, and I claim absolutely no expertise because I work at Birmingham Children's Hospital and I have availability of all of these things. But I'm aware of, the best evidence-based protocol that you can find for management of traumatic brain injury without an ICP monitoring is from the people that ran the BEST TRIP trial. And they recently wrote up a protocol called as a crevice protocol. And I have a slide if you want me to share. I have no idea absolutely as to whether this is possible to follow or not and so on. But if it may be something that people want to have a look at. That's a paper there, Journal of Neurotrauma 2020. That's a protocol there. Essentially, that relies on what you quantify as neuroworsening based on reduction of motor GCS, pupillar reactivity changes, pupillary asymmetry and Cushing's triad type stuff. Although you could argue some of those are really late signs, that and CT scan based sort of triaging of therapy and with the tiered therapy is suggested as a way of managing patients or a protocol-based management without ICP monitoring. This may be an alternative for people to use where you don't have access to, what Q-Fu said, for example, with a TCD-based monitoring and so on. Again, I have no idea as to how easy or difficult it is to follow. It's just there, and I wanted to share it.
Maybe we can ask John Abade as well for his opinion on this coming from a low-income country. John?
Yeah, thank you very much. It's a very difficult place to be when you don't have these resources to be able to manage our patients. What we basically do is what Justicia has actually outlined, but we keep on probing and looking for potential underlying causes, look out for if there is deterioration of neurological status. We look out for other causes and try to eliminate the other causes. We've had situations where we've had raised ICPs where other investigations like CT scan has suspected raised ICP not responding. But even getting the surgeons to support you is a huge challenge. So there's a place where you don't want to be, but we have to push. We have to basically do with the little we have. In some situations, for instance, in our case, it's an underlying cause of some of what we have seen is non-convulsive seizures, for instance, being a major problem. And then managing the non-convulsive seizures actually has given us some room to operate. But all these are also managed blindly. It's when we are not making headway, we are not making it, we are not seeing obvious improvement, but you see that the patient's blood pressure is going up, respiratory rate is going up, but not convulsive. We bring in seizure medication. Sometimes, or most of the time, you find out that they begin to respond, and eventually we get desired results that we. So it's a very difficult situation, especially if you are aware of the existence of some of these resources, but you cannot have access to those resources. Yeah.
That's inspiring, John, because, I think at the end of the day, if you manage etiology, you make the difference to the ones that you can. Yeah, congratulations.
Oh, and we can finally see Michaela, so thank you. There's some technical.
Sorry, technical.
So I know it's we've gone over time. We try to keep the sessions for 1.5 hours. It's been an absolutely brilliant morning. I've seen so many colleagues from the international committee. I've seen a Professor Morris, who has been one of our trainer in Birmingham Children. So great to have you online. And many colleagues from South America, from the Caribbean, from right down to Australia and across Europe and Africa. Hopefully today we were able to share some information so that it can make a difference to your practice going forward. And thank you all so very much. Our next session would be in 3 months' time, and we haven't got the themes yet, but if you keep an eye out on Twitter, and I will share the session via the WFPICCS education group. My colleague from Seattle, Amelie, who is doing great work in Kenya as well, would probably likely be leading that session. So once again, wherever you are, good morning, good evening, good day, and thank you very much for joining us all. Thanks to all the speaker and especially the trainees who has taken their time to prepare their cases and